So I want to move on to side effects, but because we know that with radiation, it doesn't come with without some side effects. So let's start with SRS and the side effects that you see both immediately following SRS and anything down the line long term that you might see as a side effect.
Yeah, that's a great point. So I'm going to try to focus, Leanne, on the side effects that are most relevant, because I think you can always go down a laundry list of what could happen. And that's what we definitely do when patients consent to radiation. But I want to focus this on like what actually really matters, like not temporary side effects that will go away or side effects that like are not of great impact to the patient, but focus more on the side effects that could really impact how someone does on a day-to-day basis. So I always think of a couple of side effects in the short term and then one side effect in the long term, but it can manifest different ways. So in the short term, the side effects are seizures and bleeding. Those are thankfully very rare. It's hard to quantify that risk, but it's probably about 1%. We sometimes use preventative seizure meds for like a week to minimize that risk. Some people use shorter or longer courses. That's all reasonable. Some people don't use it at all. That's also reasonable because there are certain areas of the brain that can't really generate seizures. So if a given patient's doctor didn't recommend the seizure meds, that can be totally fine. The other risk is bleeding. And thankfully, that's also about a 1% risk in terms of a meaningful bleed, one that the patient will know is happening. And typically we don't see that very much in breast cancer. We see that more in tumors that are prone to bleeding, like melanoma, or thyroid cancer, or some ovarian cancers, as well as kidney cancer. And we still look at things like platelets and are people on blood thinners, but for the most part, that risk is also really quite low, thankfully, in breast cancer. The overwhelming long-term risk is something called radiation necrosis. And it's hard to quantify the risk of that because everybody has a slightly different definition of what that is. But what it basically means is that there's some inflammation and or injury to the part of the brain that was treated with radiation. And the first thing that can happen, and I'll share the screen one more time. The first thing that can happen that we may not know that it's radiation necrosis right away. Because radiation necrosis can sometimes mimic tumor, at least initially. So one thing that can come up is, someone has something that grew in an area that there was a tumor. For example, this is a patient who had a tumor here in the right parietal lobe, had radiation, and on the next grid there, the top center image, that responded beautifully to radiation. But what you can see over time is that there was this increasing fluffy, cloudy enhancement, meaning whiteness, around the tumor. And this was radiation necrosis, meaning there's no tumor there anymore. It's all radiation injury. And, when we look at this in another example, this is a patient who had this tumor treated, and over a long time, it grew and then grew more. And when you look at the bottom row, you see this other white stuff, which is swelling. So this is a sequence called a flare that shows swelling really well. And this can impact patients because it's not just the area that is taking up contrast. It's all of the swelling that can accommodate and that can, go along for the ride, so to speak. So, this can basically cause symptoms that are general in nature, like headaches or seizures, or it can relate to the specific area of the brain that was injured. And this is a process that goes on for a while. It eventually will stop in the vast majority of patients. It might get a little better over time, but this is like a chronic process. So it almost becomes a chronic disease. And this is one of the reasons that when we think about, SRS to large numbers of tumors, and this is an example of a case where we did, SRS to, a total of about 60 tumors over 3 sessions, pink, blue, and dark blue. This is a fair amount of radiation given to the brain. And some of these things, as you can see, have a decent amount of bulk to them. So this is probably the side effect that concerns us most about focused radiation. It is manageable. There are things we can do about it, but it does become a chronic disease that needs a lot of attention, and even the treatment options aren't always perfect.
Is there something that increases or makes the occurrence of radiation necrosis more likely, like the size of the tumor, or is there anything that makes someone more likely to develop this?
You're spot on, Leanne. So the size of the tumor is an important consideration. Bigger size means more likelihood. No question about that. Prior radiation to the same area. So if this area has been radiated before, that will increase the risk of radiation necrosis. And then other things like drug therapy given at the same time of radiation probably plays somewhat of a role. Immunotherapy is increasingly relevant in cancer. In breast cancer world, some of the triple negative patients and maybe some of the other patients who aren't triple negative are getting immunotherapy, sometimes standard, sometimes in the context of a trial. And we do think that that probably increases the risk of radiation necrosis to some extent. And so, there's a number of factors, but really size, prior radiation, and maybe a third one is what drugs are they receiving, play into that risk.
Well, and usually when you're getting radiation, aren't those drugs being held for that reason? Aren't you told to stop your treatment or something like that?
You make a really good point, and we do often hold treatment for that reason. But there are some treatments that just can't really be held. For example, immunotherapy is a good example. The half-life of most immune drugs is several weeks. So the idea of waiting 3 half-lives before you radiate the brain doesn't always seem viable. The other notion is that sometimes it's like the immunotherapy after the radiation that can be just as impactful as the immunotherapy that preceded the radiation. So, yes, we try to hold when we can. Sometimes it's just not possible.
So how do you differentiate on a scan what is actually tumor necrosis versus what is a tumor, like the regrowth of the tumor or the failure of the tumor to respond to the radiation? How is that? Is there a test? Is there a way to know the difference?
Another great question. So, the gold standard is to take the area out, and then you'll know under the microscope what it is. However, we don't want to do that every time something grows after radiation, because a lot of the times we'll be removing radiation change that otherwise would have stopped anyway. And it may be before the patient even became symptomatic. Like you could see it on a scan, and sometimes it just stops growing. In fact, most of the time it stops growing before the patient even knows that it's there. So, to go and remove it preventatively is sort of overkill for most patients. There are advanced imaging tests that can be used. None of them are perfect, and they're all better than a coin flip. Are they, physician's best guess, based on other factors? Hard to know. But tests like dual phase PET, MRI spectroscopy, MRI perfusion. We're doing a study looking at the treatment response assessment map, which looks at the clearance of contrast, over time and making inference as to what that represents. As promising as these tests are, they do have their limitations and they've been evaluated to different degrees. A lot of the times you can make sense of it based on the MRI. Initially, we really don't know what's going on, but over time, they'll fork in the road, so to speak. There'll be a classic necrosis appearance, there'll be a classic tumor appearance, and most areas will separate along those. Sometimes it's difficult to tell, and sometimes it can be a mix, like you can have both tumor and necrosis in a given patient. So it really varies from person to person, but this is a really, really common problem in a brain radiation oncology clinic because we see it every day.
Yeah, so it sounds like it's a really hard thing to delineate on a scan what the difference is. Is there anything happening with research that's trying to look at this problem and solve this for patients? Because obviously it's really difficult if you can't tell the difference between or aren't sure exactly what is happening, and the option to surgically remove the area to look at it doesn't exist.
Yeah, that's a great point, Leanne. So, the best way to avoid radiation necrosis is to minimize the use of radiation unless you feel like the benefit is there. A lot of times the benefit is there, but it's important to think about that every time we need a patient. In addition, the technical elements of the radiation can be helpful in terms of minimizing risk. If trying to minimize the margins that are used, trying to do other things to try to keep, the risk of radiation necrosis down. Holding drug therapy, as you astutely mentioned, can be helpful. On the diagnostic side, as I touched on, there are some increasingly utilized diagnostic tests that can try to make this delineation non-invasively, but none are really perfect at this point. And then on the treatment side, there's a number of treatments for necrosis. There's steroids. There's a drug called Avastin, which has been explored in breast cancer before, for example. And there are other treatments like hyperbaric oxygen and different drugs, but ultimately it becomes challenging. And I think hopefully avoiding the problem in the first place is the best way for it to prevent it from manifesting. But a lot of choice, and thankfully we haven't talked about the incidence, but thankfully this is more rare than common. So we spent a lot of time talking about necrosis. On average, 5, 10, or 15% of our patients will get necrosis when we radiate in a focused manner. So this isn't something that happens 80% of the time. This is something that happens relatively infrequently on a per metastasis. And a lot of that 5, 10, or 15% people are asymptomatic. So, I don't want to overblow the problem, but at the same time, this is probably one of the most significant drawbacks of stereotactic radiation, especially when given to large numbers of tumors or both tumors.
Yeah, I mean, when it's a problem, it's definitely a big problem. So even though that's great, to hear that the risk of it occurring, the percentage isn't as high as maybe we think it is, but when it does happen, it's definitely problematic. What about whole brain radiation? Is there a risk of necrosis with whole brain radiation?
It's extremely rare. It's been reported, we've seen a few cases of it, but it's exceedingly rare. If something grows after only whole brain radiation, meaning there was no SRS, no SRT given, it really should be thought of as tumor growth unless proven otherwise. Again, we have seen over many, many, many cases in the denominator, a handful of necrosis cases with only whole brain radiation, but they are quite rare. Whole brain radiation has its own side effects, so to keep it on the areas that are most relevant. In the short term, there is a lot of fatigue that goes along with whole brain radiation. It can happen with stereotactic radiation too, but typically when smaller numbers of targets are radiated, it's not as big of an issue. So fatigue is a big one. That fatigue can last for a few months or sometimes longer. Appetite is a problem that can also be impaired for a few months, sometimes longer. And sadly, hair loss, not in a focused manner, but whole head of hair can happen with whole brain radiation. When hippocampal sparing techniques are used, sometimes the hair loss is more gentle, or some people actually don't get much hair loss, which is an interesting byproduct of the hippocampal sparing that certainly a lot of patients really appreciate. But with conventional whole brain radiation, and even some cases of hippocampal sparing, there is hair loss, and that takes typically months to come back. The hair may be different when it comes back. It may not be as thick or as vibrant. It may be curly where it once was straight. It may be brown where it once was, different color. So that's another thing to factor in. Long term, I think the side effects I think about are the cognition that we talked about. And unfortunately, the long-term side effects are more permanent in nature, so cognitive problems. People's balance can take a hit with whole brain radiation, and we see a lot of people who don't have impeccable balance after that treatment. And then sometimes there could be some hearing loss, but usually that's not a major factor. So, those are the 3 short-term and 3 long-term side effects that I think matter most. Fatigue, appetite loss, hair loss in the short term, cognitive problems, balance problems, and hearing loss to some extent in the long term. Not everything happens in every patient. A lot of our patients don't get much of that at all, but those happen commonly enough that they are, impact a fair number of patients. So unlike stereotactic radiation, where we're talking 1%, 5%, 10%, with whole brain radiation, many of these things can happen. It's just to what extent, and that's certainly an issue to consider.
I want to go back to hair loss because with women, that's it's a really important thing, and being able to anticipate what is going to happen with your hair before you have radiation, and knowing what to expect, I think is really helpful for women. So you talked a little bit about with whole brain radiation in general, you're going to lose all of your hair. I think you might have mentioned. What about an SRS?
SRS really varies a lot, and it really comes down to the skin surface dose and just factors that are random from person to person. Like some people get side effects and others don't. But typically, a larger tumor near the skin surface, meaning one like kind of at where the brain touches the bone of the skull, more likely to cause some hair loss. Something deeper, less likely to cause hair loss. We mention it to all of our patients because you never really know. But it tends to be more of a factor for tumors that are closer to the skin surface. It tends to be patchy though. So, unless a lot of tumors are treated and the beams are coming in and out from many, many different directions, it tends to be areas that are smaller. You can cover it up more readily depending on hairstyles. So it tends to be a less significant problem, still an important one, but a less significant one, and one that often resolves more quickly as well.
How long does it take for the hair to start to regrow? Is there a period of time where you expect that hair to start to regrow in both the SRS and whole brain?
Yeah, you make a good point. And the first thing is, how long does it take to fall out? Because people, they finish radiation, the hair's intact, and everyone's like, oh, maybe they won't get it. But the hair loss won't start typically for 2, 3, 4 weeks after we do the first treatment. It's a somewhat delayed effect. So, all of our patients finish SRT with the same hair that they had when they started 5 days prior. And certainly for SRS, that's 100% true. It's just a one-day treatment. But then the question also comes about, how long does it take to grow back? And this varies in terms of like which treatment was given. Whole brain radiation tends to be a little longer. Stereotactic is really variable depending on what the skin actually got. But typically, sometimes you tell patients, 8 weeks, 10 weeks, 12 weeks, you might start to see something coming back. And, it varies from person to person. Some people get it back at 6 weeks. Some people, it takes 4 or 5 months. So everyone's a little different.
And then with whole brain radiation, well, in women, who've had like chemotherapy and they've lost all their hair, and when it starts to regrow, it generally regrows all at the same time. Like your hair comes in, in your forehead and the whole scalp at sort of the same rate, just like as if you've shaved it. It might be really slow, but I think it's a bit different or more patchy with whole brain radiation. Is that true?
That is definitely true. It depends on how the whole brain radiation is given. If hippocampal sparing is not, or if there was scalp sparing was not. What metrics were tried to be achieved on the radiation plan versus not. But yes, that's, classically with whole brain radiation, you sometimes had a dose distribution that led to most dose kind of right at the top where there's the thinnest amount of tissue for the radiation to pass through. And that means that this is the area here that the radiation, this is the area that the hair loss comes. This is the area where the hair regrows last. So people would have hair coming back in other parts, but the top center and in the middle, the hair is not coming back very well. So the reality is it really depends on how the radiation was done and to know what to expect. Thankfully, with hippocampal sparing, the hair loss does appear to be more gentle in nature than with non-hippocampal sparing techniques. There have been some metrics published. Anand Mahadevan has done a beautiful job, a number of years ago, reporting in a small study that his patients who were getting this technique initially, that they were actually keeping their hair. And he reported his metrics. We've tried to emulate those metrics. Not a perfect system, but the actual dose that the skin is getting and the scalp is getting plays a big role.
I was just thinking, obviously I've had radiation a couple times. I haven't had whole brain radiation. I know something that comes up in discussion a lot is the use of steroids. Steroids can be a really challenging drug to be on. Is that as far as, do you have to use steroids in stereotactic radiation versus whole brain? What are the indications for use of it? When can it be avoided so that patients don't have to use it? Can it be avoided?
No, it's a great question, and it's going to vary a lot based on a number of factors. I think the first factor is, does the patient need steroids even before they go into radiation? Meaning, do they have neurologic symptoms or not? And if patients don't, then the question becomes, do you want to add steroids? Increasingly, we are not utilizing steroids. So for example, in my practice, and this is not right or wrong, I never preventatively give steroids. If patients develop symptoms that warrant steroids, I will give them steroids, but in an effort to minimize the side effects that patients go through, I try to avoid steroids. Increasingly,
Is that both SRS and whole brain that you're trying to avoid using?
SRS.
Okay.
That's right. Increasingly in the immunotherapy era, we're even more concerned about giving steroids out of concern that steroids will blunt the effect of immunotherapy. Meaning the process of giving steroids can make the immunotherapy not work.
Now, I want to ask you a question that is common amongst our community is driving and how radiation affects, the ability to drive. Can you drive after you receive radiation?
This is another tricky issue, and there's no right answer. I think in general, for a given patient, it's not going to be a one-size-fits-all situation. I think it's important to talk to your doctor or your team, whoever is on your team. It could be a PA or a nurse practitioner or a nurse or anyone who you feel like you can come to ask guidance on this issue from. But the concern with driving in patients with brain tumors, including those who have radiation, are a couple of fold. One is that either the tumor itself or the treatment can to act accordingly. For example, if there's a tumor in an area that's controlling the right foot, and most of us use our right foot to go from gas to brake, that inherently poses a challenge, whether you radiate it or not. The other factor is seizures, and we worry that our patients with brain tumors can develop seizures. Thankfully, most do not. The vast majority do not. When we've looked at this in our data, of patients, about 10% of our patients with brain metastases will have a seizure at diagnosis. And then if they don't, about 10% will develop one thereafter. So taken another way, the majority of people will never have a seizure. So I don't want people to think that they're going to get a seizure. That's not the intent of it. But the concern is that, what if someone's behind the wheel and all of a sudden they, are not aware of their surroundings or they lose consciousness, and that can be a significant issue. So radiation, especially when given in a stereotactic manner, carries some risk of seizure. It's small. The estimates are not well elucidated, but it's probably on the order of a low single-digit percent, 1%, 2%, 3%, something like that. Some centers give preventative seizure meds with radiation to prevent that seizure for a short period of time. But I think most of us would acknowledge that around the time people are getting SRS or SRT, they probably shouldn't be driving because of that small risk of this. In people who are getting whole brain, sometimes you just don't feel up to driving. Like if the patient is tired or nauseous or it's just feeling sluggish, it just may not be the right time to drive. So in general, around the time people are getting brain-directed radiation for brain metastases, we generally advise not to drive. Thereafter, it really depends on the individual circumstances. And again, this ends up being sort of a team discussion.